Hello, everybody, our colleagues. This is the evening session. In Turkey, it's 6 o'clock in afternoon. It's 6 o'clock p.m. Sorry, the latest interventional. The topic is latest interventional cardiology. I'm the chairperson, Oktay Ergene from Turkey. Sorry, Zoom gitti yalnız. The session is latest in the interventional cardiology. I will chair with Arash Hashemi from Iran, and I'm Oktay Ergene from Turkey. It's 6 o'clock in the afternoon in Turkey, and the first presenter is from Italy, Italo Porto, and the topic is IVUS and OCT in coronary intervention. Please, Italo.
So, thank you for the invitation, and I am Italo Porto from University of Genoa in Italy. So I'm going to talk about the intracoronary imaging in coronary interventions. Why do we have to use intracoronary intervention at all? Well, because there is a geometrical limitation with angiography, because we project a 3D structure over a 2D screen. So although we use different angulations, we do not have a proper assessment of the residual lumen. And by the way, we also have no information at all on plaque composition and characteristics. We only have indirect inference. So we must use techniques which increase our resolution to see objects and to properly evaluate disease which is micrometrical. So we use mainly two techniques based on ultrasound, which have a trade-off between resolution and penetration, and we use techniques based on light, which do not have this trade-off, but are in general limited in terms of penetration. More recently, high-frequency ultrasound, so high-frequency IVUS is bringing ultrasound-based techniques close to light-based techniques in terms of resolution. What's resolution? We're talking about tomographic image, so slices. So we have 3 axes, and we have longitudinal resolution, meaning how many slices we have per millimeter. We have axial resolution along the A line, so along the scan line, and we have lateral resolution, which is between each scan line. So 3 axis, 3 resolution. What we're talking about when we talk about IVUS and OCT resolution. For IVUS, we're talking about hundreds of microns. For OCT, we're talking about tens of microns. However, tissue penetration is definitely better for IVUS. More recently, as I said, high-resolution techniques have brought IVUS close to OCT in terms of resolution and so definition to see smaller structures. Newest machines, IVUS machines, have brought lateral resolution close to IVUS or axial resolution quite close to OCT. So lateral resolution close to OCT or axial resolution close to OCT. So we now have HD IVUS, which is an interesting technique. So what are the main features that we have to look for in IVUS pictures? First of all, we need to identify the lumen and trace a polygon, which is the lumen border. But the second structure that we have to identify on IVUS image is the external elastic membrane or external elastic lamina. So let's look at histology. So we need to mainly identify the lumen border. We cannot see the intima properly, not even with OCT. We do not have this kind of resolution yet. But we can see the lumen generally. What we have to identify is the border between adventitia and media, meaning the external elastic lamina. If we are able to identify this structure, we are making progresses in our IVUS and OCT identification. So let's look at an IVUS picture. In this case, we can see that the IVUS probe and the wire on which the IVUS probe is mounted is in a lumen which is not the true lumen. You can clearly see that the external elastic lamina, this black membrane which differentiates the media from the intima, is continuous in this lumen. It is not in this other lumen. So the probe is in the false lumen. Manipulating the probe and the wire, we can gain the true lumen. This is a very important use of IVUS in order to differentiate true lumen from false lumen. This is, for example, extremely useful in CTO interventions. Another important point, another important question we can answer, we should answer with IVUS is, can we predict the significance of a non-left main lesion with IVUS? Okay, I understand that this slide is a little bit too crowded, but trust me, the short answer is no. We cannot predict the significance of a non-left main lesion with IVUS. FFR is the standard of care for functional assessment of lesion severity in intermediate stenosis. We should not use IVUS for that. The only type of lesion in which we can use IVUS for identification of significance is the left main. In the left main, anatomy is quite well correlated with function, and moreover, we can use IVUS to gain valuable information that guide the PCI, if needed. So, as I said, the correlation between FFR values and MLA, meaning the smaller lumen area that we can identify with IVUS, is quite good in left main, is very bad in non-left main. So, easy answer, don't use IVUS for identification of a significant stenosis if you're not in the left main. Moreover, IVUS details in the left main are correlated with prognosis. So if you identify a lesion which is a minimal lumen area which is bigger than 6 mm², you identify a population of patients that are going to have a good outcome without revascularization. So again, let's simplify. 6 mm² in the left main is okay, and 3 mm² minimal lumen area, residual area in each of the two branches of the left main is correlated with good prognosis. And what if you stent? Well, use IVUS. You should use IVUS to guide stenting of the left main, because IVUS is associated with improved hard endpoints, and again, you should aim for a very easy rule, for very easy targets, obtaining 5 mm² in the circ ostium, 6 mm² in the LAD ostium, 7 mm² in the polygon of confluence, 8 mm² in the proximal left main. If you obtain this kind of value at post-PCI evaluation, you are doing a good PCI in the main. And again, these optimal results are associated with optimal procedural results are associated with optimal long-term prognosis. What about OCT? With OCT, you have higher resolution. You can more or less identify the intima. You can easily identify the media, and you can sometimes less than with IVUS, but quite often see the external elastic membrane and the adventitia. You can clearly see the first levels of atherosclerosis, so intimal hyperplasia. You can identify some features which are pointing to some type of plaques. So fibrofatty plaques or fibrotic plaques are associated with high backscatter, low attenuation slope, and homogeneous texture. Lipid-rich plaques are characterized by very fast attenuation of a plaque which has a bright top, and you don't see the edges. With calcium, you see the edges quite clearly. So you see sharp edges, signal intensity is low, and signal does not attenuate fast as it does in the lipid plaques. Again, this is calcium. You can clearly see the sharp edges. You can identify and you can measure the cap thickness in plaques, but in general, in normal patients, you see all these features all these features together. So you see variable, all the typical features, you see them in a single patient. OCT is very important to study ACS patients because you can clearly see thrombus, and you can differentiate between the three main causes of coronary thrombosis of ACS, which is associated with thrombosis, so plaque rupture, plaque erosion, and calcified nodules. Thrombus is very clearly seen with OCT. It's a feature you should not miss. And you can also infer the composition of the thrombus, because you can see wide thrombus, which has low attenuation, as well as, and you can see high thrombus, which has high attenuation, and you don't see beneath the thrombus. So you can clearly see a ruptured plaque in ACS. You can also infer if a plaque is eroded, because you see thrombus, but you do not see ruptures, and the fibrous cap is intact. And there is some provisional data which point to rupture yielding a worse prognosis than erosion. Also, rarer causes of ACS, such as calcified nodules, can be identified. They are associated with ACS if you can also see thrombus. Also, spasm as a specific aspect of OCT. And you can also identify aspects which are typical of spontaneous coronary artery dissection, or SCAD, because you can see an intramural hematoma, and sometimes you can see flaps in the intima. Also, some features you are able to see after stenting, so intrastent thrombus, intrastent dissection, tissue prolapse, and malapposition. Also, you can measure malapposition length in longitudinal and in axial slices, and this is quite important to obtain optimal stent apposition. So what do you do if you see, what do operators do when they see unfavorable OCT features? Sometimes, so most often, they give some other balloon inflations. In other cases, more rarely, they put another stent. And if you obtain optimal OCT results, you have a better prognosis, which is associated with absence of irregular protrusion and larger minimal stent area. Again, Francesco Prati's results show us that if you obtain optimal OCT results, you have optimal long-term result in terms of prognosis. Preliminary data also tell us that there is no large difference between OCT guidance and IVUS guidance in terms of long-term results of stents. This study, the Lumion 4 study, is ongoing and will clarify, because this is a very big study, whether angiography-guided PCI or OCT-guided PCI with a protocol which is based on external elastic lamina measurement is better. We are anxiously waiting for these results in order to clarify whether OCT guidance is needed in complex PCI. So let's put everything in context. I mainly think that in the left main, for significance, we should use FFR, but we can also use IVUS. I should also say that we may use OCT in the left main as well, but not in the ostial lesions, because these lesions are not clearly seen with OCT. Same for the right. OCT is unfeasible in ostial disease. When you see haziness, so you see something, but you do not understand what you're seeing, well, use imaging, and OCT in this case is better than IVUS, especially for culprit lesion identification. If you see intermediate disease, you are sure that it is intermediate, but you want to look for significance, well, use FFR, do not use imaging. For guidance of PCI, left main, IVUS has more data than OCT. Long stenting or old style BMS, use imaging. IVUS has better data than OCT, but we are anxiously waiting for more data. And for other complex PCI types, you should use imaging, whatever you like. So thank you very much, and thank you for inviting me in this fantastic course. Thank you.
Thank you very much, Dr. Porto, for this nice speech. We will take the questions over chat and at the end of the session. And Dr. Arash, will you please present the second speaker, please?
Thank you very much. Thank you, Dr. Italo, for a very nice presentation. I would like to invite Alexandru Mischie from France. He will talk about tailoring the antiplatelet therapy, and we were very excited about his input regarding the new ESC guidelines. So I give room to you, Alexandru. Hopefully, we will learn a lot.
Hello, dear friends. Thank you so much for inviting me as a faculty at your excellent Congress. I will try to share my screen right now in order to access the presentation. So I have been asked to talk about tailoring of antiplatelet therapy post-PCI. I have no conflict of interest. So why do we give prolonged antiplatelet treatment? Maybe the first thing why we give antiplatelet is to avoid late and very late stent thrombosis occurring, especially after the first generation of DS. Second point is to reduce the long-term risk of non-stent related myocardial infarction as well as stroke. Now, what are the risk scores validated for our dual antiplatelet therapy duration? We have more or less two very good scores. These are the precise depth score and the DAPT score. We'll just try to give you an example and try to present a case of a 68-year-old myocardial infarction patient. This is his initial presentation. He has a normal right coronary artery, but he has an anterior STEMI, which I was able to stent by a long DES in the LAD. So this was a primary PCI for myocardial infarction in the first hour. The patient received clopidogrel and aspirin and heparin. He had no prior cardiovascular disease. He was a smoker, mild COPD. He had a mild renal disease at 48. So he was reperfused with a Xenix stent. And yet, at the end of the procedure, the patient was asymptomatic. He had a normal ejection fraction. He was dismissed 4 days after his initial presentation. So I'll just try to calculate our scores for this patient. He has a DAPT score at 1. He has a precise depth score at 26. Now, which score to trust, because the two scores contrariate themselves regarding the dual antiplatelet strategy on the long run. The patient was doing fine afterwards. He visited me at 1 year and 3 months after the initial event. So I followed the recommendation and I stopped clopidogrel and continued aspirin along with beta blocker and statin. However, 5 days after stopping the clopidogrel, he developed a stent thrombosis in the LAD, which you can clearly see here. I was able to unblock the artery and to have a manual thrombectomy, then a balloon angioplasty by 3.5 balloon by 12 millimeter, and then IV agrostat for 24 hours. He had an optimal angiographic result after 24 hours. And I also performed OCT. The OCT clearly showed that there was a small part of malapposition, which I dilated, of course, by this balloon of 3.5 by 5. Now, what is the pathogenic mechanism of late stent thrombosis and very late stent thrombosis? Is it the uncovered strut? Is it the malposition? Is it the neo-arteriosclerosis? Is it the underexpansion? Is it all of them? Well, it might be all of them. Now, we have a new tool which is now available to us. And this is the 2020 non-STEMI guidelines. And there is some important information within these guidelines, especially regarding the long-term dual antiplatelet treatment. As you can see, you have to balance the ischemic risks versus the bleeding risks in each patient. So tailor each treatment according to the patient characteristics. I will just refer to treatment after 12 months from the initial presentation. So as you can see, after 12 months, we can either go by aspirin or rivaroxaban, or we can either go by aspirin and ticagrelor, or aspirin and prasugrel, or aspirin and clopidogrel. This is for the low bleeding risk patients. Of course, for the very high bleeding risk patients, we have to do just eventually clopidogrel. I will put on the next slide. The 2020 non-STEMI guidelines state that double antiplatelet treatment for more than 12 months are a class 2A indication in patients at high risk for ischemic events and without increased risk of major bleeding. Double antiplatelet treatment is a class 2B indication in patients with moderately increased risk of ischemic events and without increased risk for major bleeding. So this is what the experts tell us. And here I inserted the risk criteria for extended treatment with a second antithrombotic agent. Now, we can have the risk enhancers, which are the diabetes, history of recurrent myocardial infarction, any multivessel CAD, polyvascular disease, premature or accelerated coronary artery disease, inflammatory disease, or renal function disease. Also, we can have diabetes mellitus, history of recurrent myocardial infarction, polyvascular disease, and again, renal disease. And what they included in these guidelines they included the technical aspects, which were also present in the 2017 guidelines, but here they are more clear. So technical aspects that balance towards an increased risk for extended treatment with second antibiotic agent are at least 3 stents, at least 3 lesions treated, total stent length of more than 60 millimeters, history of complete complex revascularization, so that means left main bifurcation stent with more than 2 stents, and a history of stent thrombosis on antiplatelet treatment. I inserted here also the major and minor criteria for high bleeding risk according to the Academic Research Consortium for High Bleeding Risk at the type of PCI. So you have major criteria and minor criteria. And also on these guidelines, the experts show what are the treatment options for extended dual extremotic or antiplatelet therapies. So here we have the drugs, the dose, and the indication. We have the double antiplatelet regimens for extended treatment, including aspirin 75 to 100, which can be rivaroxaban 2.5 milligrams daily. We have VAPT regimens for extended treatment, including aspirin 75 to 100. That is clopidogrel 75 milligrams, that could be prasugrel, that could be ticagrelor in post-myocardial infarction. What I forgot to mention is that we can also do, for the low bleeding risk patients, we can do ticagrelor alone. This is, we can introduce this measure after 3 months, starting at 3 months following a double antiplatelet treatment. So we can have also ticagrelor in monotherapy. Thank you very much for inviting me, and I am waiting to see all of you on the live congress. Thank you.
Thank you very much. Do we go to questions and comments now, or are we going to finish the presentations first?
We would like to take the questions after the whole session, I think.
Okay.
Yeah. You can present the other speaker also, please. Arash is dropped from the, I think he dropped.
Okay, Dr. Sarraf is, okay. It's my honor to welcome Dr. Sarraf from the United States, who is a pioneer in TAVI procedures, and he will teach us about patient selection in TAVI, and we are very excited to see his lecture.
Hi, my name is Mohammad Sarraf. I'm going to cover the topic of patient selection for TAVR. These are my disclosures. So by way of background, we know that based on the guidelines of 2017, in patients who have severe calcific aortic stenosis in prohibitive risk and high surgical risk, clearly TAVR has class 1 indication based on so many different clinical trials. And in intermediate risk surgical cases, TAVR received a class 2A indication, and SAVR, which is surgical AVR, continued to be class 1 for many of the intermediate surgical risk patients, and clearly for low surgical risk patients, mainly because at the time the low risk trials were ongoing. From first-in-man TAVR that was done by Dr. Krebier in 2002 until this year when we received the results of the Partner 3 for 2-year follow-up, we've come a long way. We've learned a lot. We have experienced a lot of lessons. And as such, there are great expectations and anticipation by this novel technology. What's really important in low-risk patients is that roughly about 80% of the patients who have severe calcific aortic stenosis are really low risk, and in this very elegant study that was done by Dr. Thrani and the co-authors, the in-hospital mortality in patients who have low risk continues to be extremely low at 1.5%, with also very low risk of stroke at 1.2%. So clearly, our surgical colleagues are doing a remarkable job for patients who have low risk of aortic stenosis and when they go to the operating room. In ACC 2019, two very important trials were published. One was Partner 3 trial, and the other one, Evolute Low Risk, both of which compared TAVR in low-risk patient population with surgical AVR. And immediately after the release of the two trials, although the results were a little bit different in Partner 3, it seemed that TAVR, at least in 1 year, is superior to surgery, and in Medtronic valve with the Evolute R or Evolute Pro, it was at least non-inferior to surgery. And immediately we had a huge reaction both from cardiology community as well as mainstream media, that it seemed that surgery for aortic valve replacement seems to belong to history. But what's really important is that we always have to go to the details to understand the patient population that have been studied in either study. So clearly the indication was very clear. This is a very clear garden variety calcific aortic stenosis, but what's more important and unfortunately less frequently talked about are the exclusion criteria. Patients who had very small or very large annuli were excluded. Specifically, bicuspid aortic valve patients were excluded. Patients who had severe calcification, specifically in the LVOT, were excluded. In Partner 3, patients who had high syntax score, in other words, more than 32, were also excluded. And very similar criteria, inclusion criteria, applied to Evolute Low Risk, although not exactly the same, but similar enough. Yet again, in exclusion criteria for Evolute Low Risk, even syntax score of intermediate risk patients were excluded. So as we can see, they have been very particular about which patient comes into the study. And that's why in Partner 3, about a third of the patients who went to committee research meetings were excluded from the study, and in Evolute Low Risk, roughly about almost 15%, 14.8% of the patients were excluded. I'd like to focus a little bit on the primary endpoint of Partner 3, mainly because this is a study that most people refer to as superiority of TAVR, and clearly the endpoint, which was a composite of death, stroke, or rehospitalization, was in favor of TAVR at 12 months, and also recently we learned that at 24 months. So TAVR seems to be doing better. But when you scratch the surface a little bit more, death or disabling stroke, which was strongly in favor of TAVR in 12 months, seems to have lost its edge in 24 months. When we look at stroke, again, the same way. In 12 months in favor of TAVR, in 24 months, it doesn't seem to be statistically different between the two, although numerically in favor of TAVR. And death, there was a relatively good trend for TAVR. Yet again, at 24 months, that trend is completely gone. So that begs the question that, is it that TAVR should be offered to any patient, regardless of their risk, low, intermediate, or high risk? In order to answer that question, first we have to understand the huge amount of gap in evidence. And we also have to appreciate and respect the pitfalls of both technologies, either the TAVR technology and also SAVR, despite the fact that it has decades of experience behind that. And some of them really worth mentioning at a little bit deeper level. So in long-term follow-up of patients of Partner 2, which was mainly intermediate risk, specifically it's important to mention here that this is SAPIEN XT, this is not S3. So if you look at the first 3 years, clearly TAVR is at least numerically better than SAVR, but clearly non-inferior to SAVR. But roughly about year 3, things start to switch, and as you can see, the Kaplan-Meier curves diverge. Again, not statistically significant, but now TAVR, at least numerically, seems to be doing worse. And as you know, in intermediate risk patients, we are going to follow these patients for 10 years. No one really knows what the exact mechanism of this switch is, but one of the mechanisms that also has been referred to in the paper is possibly the PVL, which roughly about 3% of the patients have moderate or severe PVL. Clearly, these patients continue to have really bad outcome, even early on. Within the first few months, you can see that the Kaplan-Meier curves continue to diverge and then continue up to 5 years. And actually here, number at risk is barely anything. So many of the patients who had moderate or severe PVL have died. And even mild PVL seems to have a trend, although it's not statistically significant. Permanent pacemaker. We always treat permanent pacemaker as if it's not a big deal, but it seems that at least in TAVR patient population, it's associated with increased all-cause mortality, readmission, and emergency visit. And these, again, these trends seem to have started very early on, even within the first year. Bicuspid aortic valve syndromes, as I'd like to call it. Bicuspid aortic valve is not just the aortic valve disease. Frequently, they can be associated with root disease or aortopathy and other comorbidities, even as complex of congenital heart disease such as coarctation. So just calling bicuspid aortic valve disease as yet another aortic valve problem probably doesn't do the justice for this patient category. And what we know from the available clinical data in TAVR and bicuspid, clearly in early generation, we didn't really have a good outcome, no matter how we look at them. Bicuspid AS patients always did worse with TAVR, but even with newer generation, they didn't do, they overall did better, but at least in terms of pacemaker, it seems that they continue to have a pretty high pacemaker rate, regardless of technology improvement and advancement. Leaflet thrombosis is a very important topic that has been raised over the last 5 years. This is a famous paper by Raj Makkar that he clearly showed that it's present both in surgical bioprosthesis as well as TAVR, but clearly it's more common to be seen in TAVR. Now, there are different strategies that people are trying to come up with, different anticoagulations, but one elegant study that was done by one of my good friends when he was in Georgia Tech, Dr. Raghav, they have simulated the model of this coronary neosinuses, which is the space between the old calcific aortic valve leaflet and this new TAVR. And it seems that the microvortices of the neosinuses might have an impact on formation of clots in these pockets. So patient selection for TAVR in 2020, I think for high risk and intermediate risk, there is clearly an advantage for TAVR. But when it comes to low risk patients, I think we have to pause and we have to be careful. We have to wait for longer term follow-ups. So it's much more important to understand how to treat versus who to treat. Once we have a patient with severe calcific AS, understanding the anatomy in depth, not just by echo, but also by CT scan is very important. I cannot emphasize enough on the importance of heart team counseling and also getting the patient involved in decision-making. There should be shared decision-making. And sometimes TAVR is the way to go, sometimes TAVR, and sometimes maybe nothing, just VAV for patients who are too sick to have anything done for them. So in conclusion, TAVR is definitely a technology that is here to stay. It's clearly advantageous in patients in high and intermediate risk patients and in very carefully selected low risk patients. More data is required for bicuspid aortic valve, and it's too early to say TAVR for all, but it might be someday a reality. So in conclusion, we have to treat the patient, not the valve.
Thank you very much, Dr. Sarraf. That was a very, very educative presentation. And hopefully we will talk about it a little bit after the final session. Now it's my honor to present Dr. Zahran, who will talk about bifurcation stenting. And Dr. Zahran, are you ready?
Hello. Good evening, my dear friends from all over the world in the big IYAC family. I would like to thank the International Young Academy of Cardiology Board and the KVAC board for giving me the honor to participate and join in this world-class conference. I'm very happy to be here with all of you. I wish you all the best of health and success in your careers. And hopefully next year we will be able, all of us, to join each other together physically and meet each other in the next IYAC conference. So my topic will be involving coronary bifurcations, the decision-making and management strategies, and this mainly involving the provisional versus the two stents strategy. So what's a coronary bifurcation? A coronary bifurcation is a significant coronary narrowing occurring adjacent to and or involving the origin of a significant side branch. And why it is important? Because it accounts for nearly 16%, which is 1 out of 6 of every case of PCI. It carries a higher rate of procedural complications, nearly 1 out of 10 of every case. And maybe it has a lower rate of initial success rate, especially when using the complex two-stent strategies. And unfortunately, putting a lot of metal gets a higher rate of restenosis, nearly 1 out of 3 cases. Lots of classifications are available for the coronary bifurcations, from which the most famous one is the Medina classification. The Medina classification gives us 7 options, where the first digit describes the mother vessel, and the second digit describes the mother branch, and the third digit describes the side branch. So we get a 111 if the atheroma is involving all of them, and we get a 0 if the atheroma is not involving, so we get a 101 in the second image and a 011 in the third image. Only 3 of those 7, which I previously described now, are the true bifurcation lesions, which involves 50 to 70% of the overall bifurcations. The others, the 110 and the 100 and the 010 and the 001, are not considered as true bifurcations. So what's a complex bifurcation? The complex bifurcation is the one actually that needs a complex intervention to treat it. It's a true bifurcation involving more than 50% lesion in both the main branch and the side branch, and the burden of the severe atheroma extending beyond 5 millimeters to the side branch ostium, taking into consideration that this side branch will probably need a stent because it's a large side branch, more than 2 millimeters in diameter, and supplying a significant volume of ischemic viable myocardium. So a complex bifurcation lesion is a true bifurcation lesion that will need us to make a complex intervention, mostly involving a two-stent strategy to treat it. So technically, I need to assess the main branch features, the side branch features, and the angle between the main branch and the side branch. So we assess, of course, if the lesion is significant or not, the proximal and the distal vessel diameter in the main branch, the presence of calcification and the distality of the vessel. And the side branch also, you should assess the atheroma burden, whether it's localized to the ostium, less than 5 millimeters from the bifurcation or extending beyond 5 millimeters, assessing the proximal diameter, whether it's smaller or bigger than 2 millimeters, and the extent of the volume of the myocardium affected and the calcification and distality. Regarding the angle, it's very important to recognize the angles that less than 70 degrees versus the angle that are more than 70 or closer to 90 degrees, because there are some favorable techniques according to the angle. And then after that, you need to know to assess the sizing of the vessel. How can you assess the main branch? The main branch or the mother branch is equivalent to 2/3 multiplied by the sum of the mother branch extension and the daughter branch or the side branch. So you add them together and you multiply it by 2/3, like we see in this diagram here. And the angle of bifurcation is important because if you put a side branch stent and you try to adjust it exactly at the ostium, if the angle is more than 70 degrees, the upper lip and the lower lip of the bifurcation, as you can see here with my mouse, the upper lip and the lower lip are more or less aligned on one single line. So if you put a stent which looks like a rectangle or a cuboid, the stent will actually cover both of those ostiums since they are at one line. But here, if the angle is less than 70 degrees, you will miss a part of the upper lip if you adjust it at the lower lip. And if you put this stent actually proximally up there and you try to cover here the upper lip, you will have a significant length of the stent protruding into this vessel here and causing flow obstruction. So this is important because it helps you for wiring the side branch, and it helps you to understand the effect of what's known as the carina shift, and it helps you to choose the appropriate technique in case of two-stent strategy. The next thing is explaining what is the meaning of the carina. So let's say that this is one river here, and this river gives two branches. And you are standing here at the river side or the river bank. You can put your foot in the water here actually, or you can swim here near the river bank and you will not drown, because you know that the velocity of the blood flow in this direction is actually low at those sides. But also you know that the highest velocity of the blood is actually here at this zone. So this zone is actually the flow divider or the carina. We need to know actually when there is atherosclerosis involving a coronary bifurcation, actually most of the atheroma burden is located here and here and not located here. So it's not located at the carina. So if you put a stent extending from this main branch towards this side branch, for instance, and this flow divider or carina is moved towards here, you will get a pinch in this side branch. And if you get a pinch in this side branch, you should not be so worried, because actually, no problem, because you just need to dilate here and reconstruct or realign this carina to its normal position again. So the carina is usually free from atherosclerotic lesion, and the side branch compromise is usually due to carina shift rather than atherosclerotic plaque shift. And there is the importance of the carina kissing, because it actually realigns the carina to the proper place. And as you see here from histology, this was what I was describing to you, that you have the atherosclerosis actually here, while the carina is more or less free. So the next step is how to decide regarding this bifurcation, how you're going to plan your intervention procedure. You need to record several views from various angles in order to obtain a comprehensive picture of the lesion characteristics, of course, and to carry out the technical procedure appropriately. So, of course, you need to identify the significant lesions, the hemodynamically significant lesions, whether by intracoronary imaging or intracoronary physiological studies, or very tight lesions that are more than 90% by visual estimations, taking into consideration that they supply a significant amount of viable ischemic myocardium. And then you decide to choose your strategy, whether provisional stenting from the mother vessel extending to the mother branch and crossing over the side branch. This would be favored if at least you have 4 out of 5, you have an ostium of the side branch which is healthy, the side branch diameter is small, the side branch lesion is not extensive or long. It's easy to access this side branch even if a carina shift occurs, or this side branch is not important even if I lose it because it supplies a small volume of the myocardium. Of course, if this stuff is reversed, actually, you will be favored to be using 2 stents in case of 1-1-1 true bifurcation, side branch diameter is big, The lesion is really extensive in the side branch. It's difficult to access, so you need to actually secure this side branch by stenting it first, or this side branch cannot be sacrificed because it supplies a large volume of myocardium. Of course, you need to prepare your tools, your guiding catheter, wires, balloons, stents, and then you should go with your steps. So, are you going to wire both vessels in every single bifurcation as a routine? This is a very debatable issue. Yes or no? You need to assess the diameters of the main branch and the side branch. You need to assess the angle to choose the technique, and need to decide the 1 or 2 stent strategy as we said previously. So, people who are defending wiring of both vessels, it's safe. It maintains access to this side branch whatsoever happens. It allows you to modify the angle if the carina shift occludes the side branch. And here you need to look at the carina like a sliding door between two rooms. The door is located between the two rooms. If you open one room, which is one side branch, the door is shifted automatically to the other room, to the other side, and occludes it. So if you have a wire, if you have a little piece of rock opening this door, you can still maintain access to the second room. But if you do not have a wire, you do not have an access to this, actually, the room could be totally closed and you cannot open this door again. It marks the side branch patency in case of any salvage procedure, as we will see on later, and it helps you to anchor your guiding catheter, and it can help you in many, many bailout situations. As you can see, this is one of them. You put the stent provisional from the mother vessel to the mother branch. You crossed over the ostium of the side branch, and you could not access. It's occluded. But since you have this wire, which is even behind the stent struts, you can pass a very small balloon, 1 or 1.25 with a single dot, and you can easily dilate this very small space here, and you can maintain access to the side branch using a third wire. You can pass from here to there, and then you can perform a pre-dilatation here to the side branch or this stent, and then you can have a pot, and then you can access the side branch. Side branch pre-dilatation before putting the stent in provisional stenting is not a routine. So side branch wiring is a wise decision, but routine side branch pre-dilatation, no. Why? Because there's a risk of dissection, and most of your 1 stent cases will be automatically shifted to 2 stent cases. But sometimes you need to do a pre-dilatation, especially if there is a subtotal occlusion, or there is a very long lesion in the side branch, or the side branch is calcified ostium and it's difficult to access. Then it would be better to prepare the side branch before you do the provisional stenting. And then you come to the stenting, so you need to choose the stent diameter. Do we choose according to the main vessel? Do we choose according to which? We choose according to the distal landing zone size, and then after that you will do a post dilatation proximal to the flow divider here with your non-compliant balloon distal spot landing just at the flow divider. This is called the pot. And as we can see here, you put the balloon immediately proximal, or the distal margin of the balloon or the distal shoulder of the balloon will be just touching the flow divider, and you will do the dilatation here proximally, and this is called the pot. Of course, the pot will allow you to make a rewiring to the side branch easily, and would allow the full expansion of the mother stent, and it will avoid the mistake of rewiring under the stent struts. As you can see here from this angiography and IVUS image, from the baseline, this is a bifurcation lesion involving only one of the daughter vessels, and here you put a provisional stent towards this vessel, and then you got pinching of this one because the carina was shifted towards the side branch. Here, after that, you made a simple dilatation to this one side branch here. And of course, the carina was repositioned again and everything was fixed. You did not need to use 2 stents here. So after that, if you're gonna perform a 2-stent strategy, you need to rewire from the mother vessel to the side branch. And here you need to rewire across the distal cell of the mother vessel stent for the final kissing inflation. And after that, you will perform the final kissing inflation using short non-compliant balloons. So as you see here, if you perform a wiring through the proximal strut and then you do the kissing, you get a deformation of the stent opposite the ostium of the side branch, versus here, if you pass through the distal strut and then you make your post or your final kissing inflation, what do you get? You get very good scaffolding of the ostium of the side branch. Of course, remember that the final kissing corrects the side branch compromise. It corrects the deformity of the main branch stent. It allows proper scaffolding of the side branch stent, and it realigns the carina or reconstructs its position so both vessels are open. Thank you so much, and hopefully we can see you physically and meet face to face in the next IYAC conference.
Thank you.
Mohamed said, oh, sorry, Arash.
Thank you very much, Dr. Zahran. So we are now ready to have the questions from the audience, with which Oktay will direct them to the speakers. Go ahead, Oktay.
Yeah, we have very limited time, but we have 1 or 2 burning questions. One question is from Lebanon, from Alex. He is asking to Mohammad Sarraf regarding the TAVI. Is age is a issue for deciding? Actually, at the end of the day, what is your opinion about young, low intermediate risk patients regarding TAVI? He is asking the age. Mohammad.
Excellent question.
Yeah.
That's a very good question, and that's why I wanted to go into the details of specifically Partner 3 trial, because Partner 3 is the one that everybody says TAVR is superior, and it is if you go by just 1-year data. But the problem is that there's actually a paper that has been published in 2017. If colleagues have not read it, I highly recommend that everybody should review this paper in New England Journal in November of 2017 that has actually compared mechanical versus bioprosthetic and mitral and aortic position. And you would not be surprised that the younger the patient is, if you put a bioprosthetic valve, the mortality, I'm not talking about heart failure readmission, I'm not talking about reoperation, the mortality of patients at younger age with bioprosthetic valve is higher. Now, this study is a observational study. It's not randomized controlled trial. You can argue that in this study, those who got a bioprosthetic valve, they probably were sicker or they couldn't tolerate warfarin. That's why they chose a bioprosthetic valve. Nevertheless, we always have to keep in mind the best function of any bioprosthetic valve, either in mitral or aortic position, is the day that we place it in. From the second that we place it in the body, it starts to deteriorate. So I'm an interventional, I'm a structuralist. I'm not a surgeon, but trust me, I want to do as many TAVRs as I can. We do roughly about 220 to 240 a year. But we are very aggressive with surgical AVR for our low-risk patients. But when I say low-risk patients, I'm talking about young low-risk patients, because you can have a 65-year-old who's low-risk, or you can also have an 80-year-old who's low-risk. These two patients, we just don't treat the number of SCS. I always say that we don't treat numbers, we don't treat pictures, we treat patients, not numbers or pictures. So my point is that It's a very good question in terms of we have to have a very careful selection for the patient's comorbidities and the age. I can go into further detail, but I know that we have a limited time, so I'd like to pass it on to the next question.
Thank you very much for this, Dr. Sarraf. And another question for Alexandru Mischie. Dr. Mischie, what is the main difference in the 2020 non-escalation myocardial infarction guideline about the antiplatelet therapy? What's the main difference?
So yeah, thank you. I think the main difference is not the main, but the most important difference is the prolongment of double antiplatelet treatment after 1 year. So each decision has to be individualized according to the patient characteristics and according to the bleeding risk and the ischemic risk. And the 2020 guidelines bring a more clear message regarding the high ischemic risk, and especially regarding the anatomy and the previous procedure, PCI procedure on the patients, like patients are at higher risk for stent thrombosis and require longer double antiplatelet treatment if they have 3 vessels treated, or if they have at least 60 millimeters of stent, or if they have left main. So I think this is one of the most important messages regarding the double antiplatelet treatment. Of course, they incorporated all the recent studies, the TICO study and the other studies. So I think a careful lecture of the guidelines is necessary, and it is very difficult to sum up just in 1 minute.
Thank you very much. Sedat, do we have more 3 or 4 minutes? Sedat? If we have, so they can't hear us, I think. Let's go on. I would like to ask, Dr. Mohamed Zahran. The question is for you from Iran. Mehtat is asking, please briefly explain how to protect the side branch jailed balloon technique. Very briefly, please.
Yes, okay.
And after that,
you want?
After that, Arash will comment and we will close the session.
So first of all, as we said, there is no complete, let's say, algorithm that you have to wire the side branch. But when you are wise enough to work, you know how to avoid complications. Occlusion of a significant side branch is not a nice complication that you would like to see in the cath lab. So as you grow older, you will play it safer and you will play it wiser. So you know that you should wire the side branch from the start. Sometimes when you put the stent extending from the mother vessel to the mother branch and you inflate it very good and very adequately, sometimes you lose contrast flow to the side branch. But you have a wire always marking your position. So you have one of 2 options. You can take a 3rd wire and you can try to track this wire from inside the stent, and maybe you are lucky enough so you can wire the side branch without doing any other steps. But sometimes you cannot at all, because as I told you, the carina is a sliding door between 2 rooms, and you opened one door, so the carina totally moved and closed the other room. In this particular situation, you can pass a very small balloon across the wire that's already jailed by the stent, and this very small balloon can give you a very small space where the contrast will pass again to the side branch and you can see it properly, and then you will use the 3rd wire to pass from inside the stent to the side branch. Some operators, I have seen them also, seen Omar from Turkey also previously, sometimes if this side branch is very significant, he can inflate the stent into the main vessel to the main branch, and he can have his small 1.25 millimeter balloon already jailed there, just in case this happened. But I mean, this is an advanced complex procedure, not for everyday practice. So keep it safe, keep it wise. Wire the side branch. This is the rule. If this side branch is significant, wire it, please. Number two, if you lose it, use a third wire to track it from inside the stent. And if finally you cannot re-achieve this side branch again, just use a small balloon across the jailed wire and it will open the track. And of course, in this case, do not never forget to make the final pot to make a proper apposition for your stent in the main branch. Thank you so much.
Yes,
Thank
Arash.
you, Mahmoud. Since we are short on time, first of all, I want to thank all of the audience and thank all of our presenters. And hopefully we will see you in flesh next year. And I have a couple of questions, if we could be very fast about it. First, I want to ask Italo Porto, if do you have any comments about OCT usage in in-stent restenosis mechanism and how to treat it, whether to do it to just pulse dilation or to do drug-eluting balloons or just to stent it again? Because as I understand, if we can understand and appreciate the mechanism which made this in-stent restenosis, with whether it's neointima proliferation or is neoatherosclerosis, we can tailor our therapy based on the findings. Do you have any inputs on that? I think your mic is on mute.
Sorry for that. I hope you can hear me now. Thank you for your question. Now, it's a very good question. I think if the restenosis is not an easy one, we should use imaging on each restenosis. So in order to assess the mechanism of stent failure, imaging is mandatory. Why use OCT? Well, with OCT, you can see much better the characteristics of neointima. Sometimes you cannot see so well what's going on outside the stent. That you can see sometimes better with IVUS. But with OCT, you can see the characteristics of neointima. You can differentiate from neoatherosclerosis. In general, I would recommend stenting if you think it's neoatherosclerosis. I can recommend use drug-eluting balloons or other techniques such as ablation. You can also use laser ablation if you have it, if there is a lot of neointima. And but first of all, you have to correct if the stent is not properly deployed. So post dilatation, it's important. And nowadays we also have other techniques. So very high pressure balloons. We also have, other techniques which you can use in under deployed stents.
Thank you very much. And my last question is directed to Dr. Sarraf. We have a very short time, but I want to take your input in patient selection for TAVR. I think it's very important which kind of valve do we have in our disposal. And I think that plays a very, very significant role in selecting the patient. And also what I think it's a little bit missing in the trials, if whether the patient, for example, has a 3-vessel coronary artery disease, whether to do TAVR and stenting and go or either go for CABG or SAVR. I think there's a missing gap in the trials there. What's your take on that?
No, you're right. So first of all, in terms of the brand of the valves, roughly about 80% of the patients they do fine with any TAVR brand, but there are 15 to 20% of the patients that you really have to individualize that. For example, if the patient has a very low EF, I try not to pace that hard, and I try to give him a valve that gives them the least amount of afterload and the highest EOA rather, not ERO, EOA, which is something like Medtronic, a supraannular valve. So there are many different characteristics that I have to go through, and unfortunately, there's not enough time to go through that. But in terms of coronary artery disease, that's why I wanted to emphasize more on the exclusion criteria of low risk. If you pay attention to partner 3, P3 trial or Evolute low risk, in P3, they excluded anyone with a syntax score of more than 32. In Evolute in Evolute low risk, they excluded more than a syntax score more than 22, which means that even intermediate risk score was excluded. So if anybody has 3 vessel disease and AS, low risk, the answer is still TAVR.
Thank you very much.
To the best available
Oktay,
data.
Thank you very much, Oktay. If you
Yeah,
have any closing remarks.
Yeah, it's time to close. I think we passed 12 minutes more we used, and I would like to thank Arash and all the speakers' contribution for this Congress. Thank you very much. I wish the next year we will be together face to face, I think. Thank you very much.
Take care. Bye-bye.